So for the next 10 minutes, I'm going to talk to you about Bordetella pertussis, which causes the illness known as whooping cough. Now, Bordetella pertussis is a gram-negative Coccobacilli. So, in order to show you exactly what that means, I went down to the lab earlier and had a look down the microscope. This is actually me. And what you can see is these pink rods on the gram stain. Now, I know that this is an amazing example, but just in case, I also went online and found one that some amateur did, and here it is. Humans are the sole host for Bordetella pertussis, which kind of makes it sound like we've won something, so it's a little bit disappointing when you find out the only thing we've won is more trips to the doctor. It's also highly contagious, and is spread through airborne droplets of bacteria, spread, for example, when you cough. It can also stay alive on surfaces for days at a time, so, for example, a doorknob, or, in this case, your desk at work when your colleague's in after the weekend. So let's talk about clinical presentation. It has 4 distinct phases. There's an incubation period, there's a catarrhal phase, there's a paroxysmal phase, and finally there's a convalescent phase. This is quite distinct in infants, but in adults or other populations it might not be as clear. Each phase is classically described as lasting 1 to 2 weeks, but this is very variable. The incubation period, before you start showing symptoms, but after infection, lasts from 3 to 12 days. The catarrhal phase, as you can probably tell from the name, is clinically indistinguishable from common upper respiratory tract infections. Symptoms include nasal congestion, rhinorrhea, sneezing, and a low-grade fever. It's the most infectious stage, although you're infectious across other stages as well, and typically it lasts about 1 to 2 weeks. The well-named paroxysmal phase is typified by sudden fits of violent, uncontrollable coughing. Often after the coughing, there's an inspiratory whoop as air is going past a still partially closed and swollen glottis. There's post-tussive vomiting. There's apnea episodes. At this stage, there's numerous potential complications, and it normally lasts 1 to 6 weeks. Let's have a listen to what a child with this sounds like. Now, as I've said, there are numerous potential complications of this disease, and a lot of them are more likely to happen within the paroxysmal phase. This is not an exhaustive list, but this is an example of some of the ones that you might see. And finally, we have the convalescent phase. This is when you have a chronic cough that's slowly resolving. Those paroxysms become less and less frequent, and the child slowly gets better. It can last for weeks to months, though. When we're thinking about treatment, we're thinking about macrolide antibiotics. That's azithromycin and that's clarithromycin. However, if you give treatment 3 weeks after the onset of the cough, that's the catarrhal phase when it's very hard to diagnose. There's going to be little benefit to the progress of the disease, and that's why healthcare professionals advocate vaccination as the best prevention. Now, as I've said before, Bordetella pertussis lasts a long time even after you've eradicated it from the system, and a lot of that is down to the virulence factors or toxins that it produces while it's infecting you. It produces a number of toxins, as is shown here, and each of these has a unique role within the infection. So let's go through these ones one by one. Once Bordetella pertussis has managed to infect an individual, it needs to find a way to adhere to the respiratory epithelium, and it does this primarily using 2 of these toxins, filamentous hemagglutinin and pertactin, and this little square shows you kind of where they would sit between the bacteria and the cilia. Now, they're not as important in terms of the pathology of the disease, but they are important in the creation of vaccines for it. Drukyl cytotoxin, on the other hand, paralyzes the cilia near the site of infection. That means the cilia can't beat, so you get a buildup of mucus, and that's suspected to be the reason why you get this violent coughing, because you're simply just trying to clear the mucus. It's also the reason that the symptoms last as long as they do, is because the airway just needs time to heal. Now, the next toxin we have is pertussis toxin. Pertussis toxin is secreted exclusively in nature by Bordetella pertussis, and its enzymatically active unit of it, shown here, has been shown to lead to the downstream inactivation of G proteins in eukaryotic cells. This has a range of systemic effects, and we'll go through them now. First of all, it leads to a lymphocytosis, and it does this through a couple of mechanisms that we'll talk about in a second. It also blocks chemotaxis and migration. It leads to a dysregulation of your insulin secretion, normally increasing the amount of insulin you secrete, so you get into a hypoglycemic state. And finally, it increases histamine sensitivity, and this has a couple of consequences that we'll talk about. The lymphocytosis is actually as a result of the release of those cells from extravascular tissues like the spleen into the blood. There's not actually any new division going on. At the same time, the toxin is reducing the ability of those cells to actually exit the blood, so they're just circulating round and round your system. If we're thinking about the change in your histamine sensitivity, that means that there's more leakiness into the airway tissue, so those individuals find it harder and harder to breathe because of that. And when we're talking about the insulin, neonates with severe pertussis have actually been found to have severe hypoglycemia, and that's often a thing that you'll find when people have severe aspects of the disease. And finally, we have adenylyl cyclase toxin. Seen here in this lovely picture I took earlier, it's another one that aids adhesion to the respiratory tract, and it does this by inserting itself directly into the cytoplasm of adjacent cells. It also has an important role inside cells. It binds to everybody's favorite calcium-loving protein, calmodulin, and leads to an increase in the amount of ATP being synthesized into CAMP. Importantly, this is unregulated and highly rapid, and it's very bad news for the target cell. First of all, this is another thing that further suppresses chemotaxis. It leads to the insertion of cation-selective pores into the cell membrane, which means that you get a potassium efflux and theoretically a sodium and water influx. And this means that the cell isn't functioning the way it's supposed to be. So what we're looking at here is an induction of cell apoptosis, and it does this through three mechanisms: ATP depletion, CAMP accumulation, and a cation dysregulation. And overall this leads to a dead cell. The relevance of this is that it's an immunosuppressive toxin. It targets cells that express complement receptor 3. That's your neutrophils, that's your natural killer cells, that's your macrophages. And in combination with pertussis toxin, it makes it a very potent bacteria. So, who's at risk? Well, babies, especially those under 5 months of age. Elderly people who may have waning immunity to the disease. Of course, those who are immunocompromised for any number of reasons are at risk. And anybody who may not have chosen to uptake the vaccination. If we're thinking about the individuals who are at risk of the serious consequences of the disease, that is, babies, then most recent data from Public Health England estimates uptake to be around 54%. The vaccination itself is generally given in the third trimester, with placental antibody transfer protecting the neonate via that mechanism. The idea being that this would protect the baby until he or she is suitable to receive their own vaccinations at around 2 years of age. It's also a very effective vaccine, protecting up to 91% of babies from becoming ill in their first few weeks of life, and that's compared to mothers that remain unvaccinated. This also protects the mother herself from contracting the illness and passing this on to the child, and that has the added benefit of protecting two individuals for the sake of one vaccination. It's been in use since 2012, and that was when the last serious outbreak of pertussis happened. It happened in May of that year, and as you can see here, it was a sudden uptick in the amount of disease reported. And the highest disease incident occurred in infants under 3 months of age who were too young to have completed the primary vaccination course, and therefore had the greatest risk of complications and death. And thankfully, the government responded quite well and quite quickly to this, introducing a maternal vaccination program in October of that year. And since that, they found that the greatest reduction in the disease since that peak in 2012 has been in these infants under 6 months of age who are targeted by the maternal pertussis vaccination program. Unfortunately, on average, uptake of the vaccination is about 54% each year, so not every child is covered. As well, the government's program on maternal vaccination, of course, does nothing for the elderly population, and there's been a rise in the amount of whooping cough diagnosed in those populations. So in terms of epidemiology, there's a reliable outbreak every 3 to 4 years, and it remains a fairly common disease even in developed countries where there's well-uptaked immunization programs. In 2010, there was about 16 million cases worldwide, and about 95% of those cases happened in developing countries. Overall, though, there's a considerable variation. So there's a few theories about why pertussis remains quite epidemic within populations, even with a good uptake of vaccination. One of them is that there's just a waning herd immunity overall. Another theory being that the acellular vaccine that they use these days is less effective than the old vaccines. And there's some research that shows that while the acellular vaccine is good at preventing the disease, it's not good at preventing infection and transmission. So there's a lot of asymptomatic people that are transmitting the disease. Another is that there's just an increased awareness of the disease, so doctors are just picking it up better. And finally, some people theorize that there's an evolving virulence of pertussis itself. So finally, let's talk about investigations. The first one you can do is a culture of a nasopharyngeal aspirate or a swab from the posterior nasopharynx. It's a definitive diagnostic test and it has a specificity of 100%. However, sensitivity is 30 to 60% if the culture is taken under 2 weeks after symptoms start, and it decreases even further if taken 3 weeks after the onset of cough. Next, you can do a PCR of the nasopharyngeal aspirate. PCR has an increased sensitivity compared with culture, but it should be taken again within 0 to 3 weeks following the onset of cough. And finally, serological tests can be used. That's more useful for diagnosis in the later stage of the disease, so that's usually 2 to 8 weeks after the cough onset. Even so, it's not that effective and it can't differentiate between vaccination response and an infection. So that's it for my presentation. Thanks for listening.